Hey guys, what's up? I decided to do a series of video going over scientific journal articles. I thought it would be a good opportunity to better educate myself as a future podiatrist, and also I like to kind of translate these scientific journal articles and make it into a simpler version so that everyone can understand. So the first article that we're going to talk about is actually a review. Now the authors of this review went through a database and searched any article that had relevant information regarding diabetic foot ulcer and preventative screening methods. So they went through databases such as MEDLINE, National Guideline for Clearinghouse database, and also EBSCO. And they use keywords such as diabetes, diabetic ulcers, and preventative ulcers, I believe, and other words. And after they did that, they came up around 165 journal articles, including 22 randomized original research. And they basically come up with a summary of how to basically prevent diabetic foot ulcers and what kind of treatment physicians should provide for the patient. So first, before we get started, let's talk about what is an ulcer. Ulcer is basically a type of wound, and wound is what a lot of people just say in common settings. Wound could be a burn, it could be a cut, it could be a bruise and such. But an ulcer is a type of wound which is basically defined as a break in the dermal and epidermal junction. And depending on the severity of the wound, it could be pretty good, pretty bad, or it could be an okay ulcer. They use different classification systems to kind of grade an ulcer. Commonly people use Wagner for pressure ulcer, or it could just be University of Texas, or it could be PETIS and other classification system. But you could basically grade. The idea is that you could grade an ulcer so that you standardize it when physicians talk about discuss an ulcer. So, and also ulcer can derive from a lot of different sources. It could be a pressure ulcer where it's kind of like a diabetic ulcer, or it could also develop a hypertension ulcer, it could be a venous ulcer, it could be an arterial ulcer, or it could be a diabetic ulcer. So in this case, we'll be focused on talking about diabetic ulcers. So now that we talk about what is an ulcer, how do diabetics get an ulcer? So the authors talked about three main points, or the reasons how diabetics patients get an ulcer. The primary reason diabetics get an ulcer is because of their peripheral neuropathy that accompanies diabetes. And the second way that they could get an ulcer is just a plantar pressure when they're walking. Oftentimes, not everyone has a perfect gait, and diabetes kind of worsens that gait by creating a plantar pressure in a localized area that could create an ulcer. And generally, it is during a heel lift phase of the gait cycle where there's the greatest amount of shear force that is placed on the metatarsal head of the feet. That is generally where the ulcers are developed. And thirdly, diabetic patients develop ulcer from trauma, meaning that oftentimes people wear not the proper size shoe, and that could lead to constant abrasion of the skin or area of the feet, and add that to the plantar pressure that could lead to focal pressure on the feet that could create an ulcer. So trauma from rubbing your feet on the shoe is the author said that it was primarily one of the main reasons they get an ulcer. So after we talk about how they got an ulcer, so what are other factors that could kind of worsen an ulcer once it's there? The main thing that the authors talk about is an atherosclerotic peripheral vascular disease that generally accompanies diabetes. And that's basically a atherosclerotic plaque build up in the blood vessels. And these generally build up from just the lifestyle that diabetic patients often have. They don't exercise as much, and they don't eat healthy. They never eat the healthiest food, and that can lead to an atherosclerotic plaque that basically impedes blood flow to an area. And if you have an ulcer, you need nutrition and immunological factors to heal that ulcer. But if you have a disruption in the blood flow because of an atherosclerotic plaque, then that could slow down the healing process of an ulcer. So those peripheral vascular disease is one of the main things that can kind of slow down healing of an ulcer. Another thing is just the predisposition of a diabetes. hypoglycemia leads to impaired immunological functions, and that process is there's a whole bunch of pathophysiology that's involved in the impairment of the immunological system due to hypoglycemia. But basically, there are nerve damage because hypoglycemia can often kill cells by drawing water into a cell and kind of burst them. So that's one way. And the last thing they talked about that could worsen ulcer development is basically the physical, psychological, and social aspect of diabetes. And I think the way I interpret that is basically diabetic patients who are often overweight are kind of discouraged from society to kind of go out and kind of fix it. They're often bullied, I think, in my opinion, where they're ostracized because of their overweight, and that could kind of lead them into a vicious cycle of where they live a sedentary lifestyle and complement that with bad diet, which could basically lead to not good immunological function, unable to heal an ulcer. So these are the factors that kind of create an ulcer and kind of develop into that kind of slow down the ulcer healing. Now, next thing the author talk about is basically how do we screen for these? How can we screen so that these ulcers don't develop in the first place? One of the main thing is basically we talked about peripheral neuropathy, that is the main leading cause of the diabetic ulcer is. So how do we detect a peripheral neuropathy? Is by doing a monofilament test. And what that is basically we use this little monofilament, like almost like a fishing line, where we poke the plantar surface of the feet to indicate to feel that sensation. And if they can, then that's good. But if they can't, then it's an indication that they could potentially develop an ulcer. The paper talks about 4 points in the feet that they could do it, but I learned in my school that we generally do 10 points. 3 digital pulps, 3 plantar heads, and then 3 points on the rear foot, and 1 point in the first inner space of the dorsal side of the foot. So 10 point total. And that kind of gives you a more specific, kind of more detailed idea of where the patient is losing sensation, and kind of leads you to a better diagnosis. So this monofilament test is one way that you can kind of screen for an ulcer, potential ulcer development. Another thing is a vibratory or tuning fork test that uses a tuning fork to see if a patient can feel vibration. You could also use a Biothesiometer. It's kind of like a tuning fork, but it sends a vibration on the skin and it basically asks the patient to come feel it. So that kind of deals with the peripheral neuropathy and kind of screens for any peripheral neuropathy diabetic patient might develop. And if they do, then that kind of tells the physician that you need to keep an eye on this patient for potential ulcer development. Now, for the peripheral vascular disease, one way to screen that is what we call an ankle brachial index, or a short ABI, where it is a ratio of an ankle to brachial blood pressure, brachial here and ankle on down there. And the ratio should, for healthy people, it should be between 0.9 to 1. And that indicates a healthy blood flow. Anything below 0.9 will start to indicate there is a disruption in the blood flow, and potentially you'll be impairing any healing process that is required for ulcer healing. But often diabetics, like I said, they develop atherosclerotic plaque that makes the blood vessel a little bit rigid and brittle at the same time, so that the ratio actually goes up even more than 1, say about 1.1 or 2, like 1.3, which could also indicate that there is a potential peripheral vascular disease. So for diabetic patients, you need to be aware that the value of ABI could exceed 1. So that's one way to screen for peripheral vascular disease. The paper talked about another method is basically transcutaneous oximeter, measuring the transcutaneous oxygen level in the area. And generally, it is well known that any the oxygen level above 30 millimeter mercury is required for a wound healing. So you could do that to measure if a patient can heal a wound properly. But the authors of the review talked about how that's not really readily available in clinic settings like the transcutaneous oximeter. So ABI is more frequently used. So those are little screening tools that a physician can do to perform to kind of get an idea if this patient's how to manage an ulcer with this patient. So there are things that the physician do to basically make the ulcer go away in a way. And the first thing is patient education. We talked about how a bunch of studies did a review of patient education, and that really matters, and it does matter significantly. So a physician educating a patient about potential ulcer development and letting them know that if they don't stop smoking, or if they don't start exercising, or if they don't start eating healthy, they could develop ulcer, does matter to the patient and ulcer formation. So as a physician, you should always tell patients, always live a healthy lifestyle. So you're the encouragement factor. When they're at your office, I think it's critical that you kind of educate them. Use that opportunity to kind of remind them. A lot of people know smoking is bad. A lot of people know you gotta exercise, 30 minutes a day or whatever, and eat healthy. But it's just that we could be that added encouragement that allows patients to heal properly. So patient education matters. And for diabetes, there's like a little specific instructions that physician can provide to patients to manage their diabetes. And it is things that include like checking their blood sugar level, checking their shoes daily, checking their feet daily, checking the temperature of water before taking a bath, and never walking on barefoot and such. Those things allow patient to get a better sense of how to manage their diabetes. Another thing that a physician can do to help get rid of ulcer is making sure that you do, once the patient comes into the office with an ulcer, making sure you're greening that callus. That could be an indication of a pre-ulcerative state. Calluses are hardened skin, soft tissue, basically a soft tissue adaptation of your body due to a constant pressure. I have some calluses over here from weightlifting, but basically you could get that on your feet. And calluses, I used to think that calluses were like an armor of your skin where it protects it, but it's not really like that. It's actually, it hardens the skin and it creates an increased risk of basically fissuring or cracking. And once it cracks deep, and like I said, it goes deep into the tissue, and it could create a break in the junction that we talked about earlier, the dermal and epidermal. And once it does that, then it creates an access point for potential infection and a bunch of bad things. So you don't want calluses. So oftentimes when a diabetic comes into an office, it's very wise to basically debride the callus so that there isn't any potential development of ulcer. And also another thing that the authors talk about is use of orthotics. Orthotics are more and more commonly accepted these days, and it's because it works. I'm not just saying that because I'm a future podiatrist, but it makes sense what it does. It basically allows your feet to kind of walk normally, where the way it's supposed to be, the way it's designed to be, and then it allows the distribution of the pressure on the feet to evenly spread out. And that basically erases the localized focal pressure that often leads to an ulcer. So orthotics works. So, and also managing sugar level is one of the important things for diabetic ulcer development. So make sure you manage sugar level daily so that you don't get ulcer. Sugar level is just high. Hyperglycemia, hypoglycemia, they're both bad. But diabetic patients often deal with hyperglycemia that leads to nerve damage, that leads to impaired immunological function, and tons of other stuff that are bad. So control your sugar level is key. And that's basically the gist of the paper, how the ulcer will develop, what factors are contributing it, and how you could basically manage those ulcers. And then the authors of the paper kind of finished the paper by saying how basically all these things are cost effective to basically screen them before they appear. They talked about the cost of treating an uninfected diabetic ulcer was about $9,300. And if it leads to if it progresses into a severe form where it leads to an osteomyelitis, that cost could go up to like $45,000. So it basically triples and quadruples the amount from an uninfected ulcer to a bone infection, basically super deep and bad infection of the bone. So that. But the $9,300 of it, treating the uninfected ulcer could also be prevented by just preventative screening. That includes regular visit to the podiatry office so that you're properly callusing, debriding all those calluses and just getting an orthotic dispense, those things can prevent even the ulcer formation. So it will probably cost less than $9,200, and that's my speculation, but it will probably cost even less than $9,200. So the paper just focuses on basically preventative care on diabetic ulcers. That's basically the gist of this paper. I hope you guys enjoyed this video. That's it. Thanks for watching, guys.